So, good evening, all the aspirants present here. We'll be continuing with the cardiology domain, and the speaker that we have here is Manidipa Majumder, ma'am. Yes, ma'am, you can take over. Thank you.
Good evening, everyone. So, I'll be starting with the remaining part of our session two, in which initially we studied about heart failures, and we will be studying today about cardiomyopathies, and into session three, which is about acute coronary syndrome and some pericardial disease pointers. Okay. So, cardiomyopathies, as you all know, cardiomyopathies are diseases of the heart's muscle. So the main three types of cardiomyopathies that we learn in MBBS level are dilated, restrictive, and hypertrophic cardiomyopathies. But once we study more, we also learn about two more, that is the arrhythmogenic cardiomyopathy and LV non-compaction, which can present either as a dilated cardiomyopathy or as a restrictive cardiomyopathy, depending on which phase we are in. So these are the five types of phenotypic types of cardiomyopathy. There are n number of reasons. Cardiomyopathies can also be classified into primary and secondary. Primary meaning the disease process only affects heart, and secondary meaning there is a systemic disease out of which heart is also affected, in which the heart the phenotypic expression is one form of cardiomyopathy. So these are the etiological types of primary and secondary cardiomyopathies. You don't have to remember every, but go through the list once, because there are many clinical scenarios that will come, especially in MRCP2. So you need to remember in which diseases you can expect cardiomyopathy as well. Primary cardiomyopathies can be acquired, genetic, or mixed. Acquired are myocarditis, peripartum, tachycardia induced, or Takotsubo cardiomyopathy, which is also called the stress induced cardiomyopathy. Genetic common variants are arrhythmogenic right ventricular dysplasia, which is also known as the ARVD or ARVC, and hypertrophic cardiomyopathy, ion channel disorders, left ventricular non compaction, and mitochondrial myopathies. There are many others as well. Mixed are dilated and restrictive types, which can be either acquired or genetic or both. Secondary causes of cardiomyopathy, we have the autoimmune, infiltrative disorders like amyloidosis, Gaucher's, Hunter's, Hurler's. Among these, amyloidosis is quite common. Among autoimmune, the sarcoidosis is quite common, which might present as a systemic disorder or as purely as cardiac sarcoidosis. In endocrine, commonly we find cardiomyopathy in hyperthyroidism, in acromegaly, and sometimes in diabetes mellitus, but in that the effect on heart muscle is multifactorial. Infectious Chagas disease, hepatitis C, HIV can all present as cardiomyopathies, but they are rarer. Among toxic cardiomyopathy, alcoholic cardiomyopathy, and anabolic steroid use is quite common and found in regular hospital admissions as well. Nutritional deficiency, kwashiorkor, L-carnitine, niacin, selenium, thiamine, and vitamin C deficiencies we can find. So I'll move on. If somebody wants to answer, they can answer. So which murmur increases with Valsalva? We had read a little about dynamic auscultation in the first class. Anybody
So
wants to answer?
hypertrophic cardiomyopathy.
Yeah. Any other murmur do you remember? This is related to cardiomyopathy, so HCM is the correct answer, sir. Any other cause which increases with Valsalva? Can you remember? Anybody? You can write it down in the chat as well if you remember. So HCM for the first question is the correct answer. Number two, which cardiomyopathy is most commonly associated with alcohol? What kind? Which is the phenotypic type of alcoholic cardiomyopathy? Is it HCM, RCM, DCM? What is it? Non-compaction? What is it? So we have DCM. DCM, correct. So DCM is the correct answer, dilated cardiomyopathy. And which cardiomyopathy shows low voltage on ECG with thick LV walls, myocardium on echo? What is the phenotypical type and what is the probable cause? Anyone wants to take a guess? Let me check. Mhm. Nobody has answered.
Restrictive.
Yeah, it's restrictive, and the most common diagnosis in this kind of scenario is amyloidosis. And somebody has written dilapidated cardiomyopathy. I have not heard of anything like that, but that's okay. It's dilated cardiomyopathy. Well, the heart becomes dilapidated. There's some truth in that. So dilated cardiomyopathy. This is one of the most common cardiomyopathy that we encounter in clinical practice, in which we see dilatation of the LV majorly. Sometimes there is RV dilatation as well with systolic dysfunction. Causes commonly are alcoholic, chemotherapy induced, viral myocarditis, peripartum, genetic cardiomyopathies, and idiopathic. The most common two variants are alcohol and viral myocarditis, and your MRCP2 clinical scenarios will mostly come from that, and also peripartum, of course. Clinical features include fatigue, dyspnea, and signs of heart failure. Complications can be atrial fibrillation because of atrial enlargement, ventricular arrhythmias due to ventricular muscular dysfunctions, thromboembolism, and sudden cardiac death. Thromboembolism because LV becomes very weak and there is stasis of blood in the left ventricle, which forms blood clots in the ventricle, which results in systemic thromboembolism. May include stroke as well. Stroke, sudden coronary occlusion, or occlusion of the vessels of the leg. Anything can happen. Investigation ECG is non-specific, which may show AF, LBBB, or poor RF progression. LBBB, see any kind of bundle branch block or intraventricular conduction delays are markers of abnormalities of repolarization or depolarization. So the muscles get stretched, they are not working very well. It is taking very long for the heart muscles to be depolarized. So LBBB, RBBB, poor RV progression, these are markers of LV dysfunction. Chest X-ray will show cardiomegaly and pulmonary congestion in case of failure. Echo, we will see dilated chambers with reduced ejection fraction. Management is standard heart failure therapy. Yes, if the ejection fraction is less than 35%, ICD is indicated, and sometimes CRT is indicated. We read about CRT indication, cardiac resynchronization therapy indication, in the last class. If anybody remembers, please write it down in the chat. I will see. Remember the CRT indications in heart failure. And of course, the definitive therapy of DCM in terminal stages is heart transplant, where nothing works. Okay. Takotsubo or stress cardiomyopathy is a favorite of MRCP questions. It is an acute reversible LV dysfunction triggered by emotional or physical stress. There is a catecholamine surge due to this stress, which causes myocardial stunning. So, what is stunned myocardium? The cells, the myocardial cells that are not contracting, but these are not dead. They're metabolizing. So they are taking up nutrients, they're taking up blood and oxygen, but they are not pumping. So this is called myocardial stunning that occurs in the initial phases of ischemia as well. So there is myocardial stunning due to catecholamine surge, which causes LV dysfunction in acute setup. The name is derived from octopus or fish catching basket. It's a Japanese word. Classical finding is apical ballooning that is seen in echo as well as in angiography. If we do an LV angiography, we can see clinical features. It mimics acute MI. There is mostly chest pain. It's not like cardiomyopathy, which presents as breathlessness. It presents as MI. Chest pain, ST elevation, troponin rise. Coronary angiogram will be normal. Echo will show apical ballooning and hyperkinetic basal segments. Cardiac MRI we can do, which excludes myocarditis. In cardiac MRI of Takotsubo, there won't be any infiltrates or any edema or any inflammation seen, unlike myocarditis, which will be positive in cardiac MRI. Management is supportive, mostly heart failure therapies. Recovery usually within weeks, but not, remember that not all patients recover. Mostly they recover, but it is not 100% recovery is not there. Complications are arrhythmias, LV thrombus, and shock.